liaison. She's with Common Sense Consulting and has is now working with us, HSCRC, to do a lot of the meeting management as well as support to some of the content, because she brings a wealth of knowledge and expertise to the table in terms of 2 decades of experience in public health program planning, implementation, evaluation, and among many, many other things. She's done lots of convening of public toward the end of public engagement. So we are very lucky to have Tiffany on board with us, and welcome, Tiffany. Thank you. Thank you. Happy to be here.
I'm Hillary Sumba with the Primary Care Coalition.
Lynn Quincy, Consumers Union.
Michelle LaRue, Casa de Medina.
And Barbara Brookmeyer, Health Officer here in Maryland.
And Teresa Lee, the Maryland Healthcare Commission.
So let me turn to the folks who are dialed in on the phone or through their computer mic, voice over IP. If you could let us know that you're on and in the meeting.
Hi, this is Doug Rose, and I'm on.
Hello, Doug.
This is Gary Vogan from Holy Cross.
Good morning, Gary.
This is Susan Markley from Healthcare Access Maryland.
Hello again, Susan.
Good morning.
Okay, so we know Karen Ann Lichtenstein is on the webinar. Okay. Okay. All right. Well, welcome, Karen Ann. Thanks for joining. Anyone else that you can see? Right. Suzanne Schlappman from Healthcare for All will join us at 9:55. She had other meetings commitment. I'm going to ask we have a person sitting in the audience, if you can come and just say hi and tell us who you are.
Hello, my name is Novella Cass. I'm the Executive Director of Community Health Services for Keswick.
Why don't you come join us at the table, unless you prefer to sit out there. Okay.
Kind of lonely up here.
Or out there. Lonely out there. Great. You can see that we do have a full agenda today. I'm going to go through a brief update and reminder about the new all-payer model and the work under that, and then later on provide an update on a care coordination work group. But and then in between, we'll have presentations and work from Lenny, Suzanne, and Lynn Quincy, who's joining us as a guest. Special guest. And so if we move to the next slide. Winner. First, I wanted to do a quick segue and recognize Lenny Preston, who's our honorable chair of this group, who's really rolled up her sleeves and her pant legs and everything else to come in here and do this work because she's passionate about engaging consumers in meaningful reform, and she's done it for the duration. This has not been a quick turnaround effort. So, and she's made lots and lots of friends and colleagues and many people who respect her, including, I'm sure, everyone in this room and those on the phone along the way. So we want to recognize you for your Families USA Consumer Health Advocate of the Year Award. And last, I guess it was this week? Friday. Last Friday. So congratulations. And you look great in that picture. So anyway, we're so lucky to have you doing that. Thank you. Thank you. Thank you.
Hello?
Yes. Hello.
Hey, Di, it's Karen Ann. I believe I win the prize for not unmuting.
Oh, no, we've had others who didn't even.
Oh, my gosh, the green button. Now I get it. Okay, I'm going to unmute myself.
Well, great. Good to hear your voice, K.A. I've known Karen Ann for 27 years, so she gets to call me Di or Di Feeney or Di Feeney Jones or whatever she wants, so that's good.
Thank you.
So we'll go head on and remind us of our public engagement charge under the new, or not charge because that's what Lenny's going to talk about, but the key attributes of the new all-payer model that relate to consumer engagement, or where consumers have the opportunity to engage. So, and Steve did this presentation last week that included this slide, which shows us that we have lots of opportunity in various input ways through an advisory council, work groups that we run, payment models, performance improvement, and measurement. That's the one that I work on mostly. And then lots of subgroups underneath there that work on a lot of technical aspects. That's in the blue bar underneath, all the blue bars. They're in various stages of work at this point, so there's juggling 20 balls or whatever. But the multi-agency stakeholder groups are where we see the biggest opportunity. Although consumers can engage at any juncture, come to my performance measurement meetings. I would invite everyone to come and enjoy that conversation. However, where we fall on this chart is the consumer engagement and consumer outreach box in the middle. There's also an alignment models work group that, again, is aligning the various provider interests primarily, and in terms of long-term care and other community-based services. And then the care coordination initiatives infrastructure is seemingly being more focused on a sort of a data utility, and I'm going to save the detail of that till toward the end to give you an update on what occurred a week ago at that meeting. There's some slides at the end. And again, the point of this whole effort is to focus the patient from the system and providers to the people who are the reason why the system exists. And so to improve patient experience, get better population health, and lower cost, all three at the same time. And then implications for consumers, which also seems like a very provider-focused set of points here, which is we want to talk about, so if we have high-quality, efficient, and effective care while a hospital maintains market share, well, what does that mean? I'm a consumer and I go to a hospital and access a number of other services that work for me and that work together with each other. So these statements here are very focused toward what does, again, it says a successful hospital look like under this new system. But we haven't yet had the conversation about what this means about better, about a system that combines the power of people getting the care and the people providing the care, and that working, that dynamic that works well together. And then, so I just wanted to remind us where we thought the opportunities would begin to lie and start in conversation here. And then with that, I'll open for any comments that folks want to make at this point, and then turn it over to Lenny to talk about some changes in the definitions and any implications for the principles of this work.
So any comments or thoughts on what Diane has presented before we move on? I think that Diane's a perfect person to help with this project because the performance measurement work that's going on, this all aligns so directly with what is going to be happening with consumers and patients. So
that reminds me, there's one other quick thing I wanted to update you on. So one of the performance measurement purview areas is to figure out how to reduce unnecessary readmissions, people going into the hospital, getting infections, stuff that they didn't go in with, didn't want, that sort of thing. So, and we know Maryland, again, has the highest readmission rate of all states for the most part. So we've linked incentives to that, to performance in that. And we're currently in the midst of deliberating what the goal should be by hospital and how much money that should be worth. So that will probably come up at the March Commission meeting. And so if you're interested in that topic and want to weigh in on that topic, the information's all posted to the web, and you also absolutely can submit comment letters or listen to any conversations. Our next performance measurement meeting is Monday, so if you want to multitask and dial in on a webinar, we do that for those meetings as well as like we do for this meeting. So that's the near-term thing that's coming up toward meeting that goal of reducing our readmissions to the level of Medicare in the first 5 years of this model, and we're sort of in the middle of that period right now. I want to update you about that. Thank you for that reminder.
Oh, you're welcome. You'd be happy to remind me about anything I forget. I should say just about the award, because I was really surprised, that really, I like to say I'm the pretty face. Fortunately, there's nobody in coalition here because they always give me a hard time for that. But really, it is the work of all of the coalition members and everybody in this room and everybody in Maryland who's really responsible for the fact that the state was recognized. I may have been standing up there, but it's really all of you that made that recognition possible. So really, my thanks go to everybody. I was invited to serve on the HSCRC Advisory Council that Diane just mentioned, and their report came out from the November meeting, and I think it's useful to just, the report was great because it singled out sort of areas of emerging consensus, and one of them I just thought I wanted to reference. Maryland leaders should strengthen their efforts to educate consumers about the all-payer model and strive to communicate model goals, implementation steps, and accomplishments in plain, understandable terms that demonstrate the impacts on consumers. This will enhance consumer engagement and promote positive results. So I think, kudos once again to HSCRC for really recognizing the importance of consumers in this process, and the Advisory Council for really picking up on that. So, and that report is interesting. It's up on the website if you want to access it. Donna, since you arrived, do you want to just say to those on the webinar so they'll know who you are and that you're here?
Good morning. I'm Donna Jacobs, University of Maryland Medical System, and I seem to have a cycle here. I keep doing conference calls right in front of this meeting and coming in late. I apologize.
Well, thanks for being here. And so we were going to turn next. At the last meeting, we created some definitions and some principles for us to base our work upon. And so we wanted to go back and revisit those. And both Donna and Hillary made some suggestions, as did others, but they're specifically I tried to address in a revised version. And so that's up for you to see. And I highlighted the areas where we made additions. So I was hoping we might get consensus first on the definitions and whether those now are everybody's comfortable with those. And I don't know if you had a chance to look at those in advance, if anybody has any comments or thoughts. The silence, Barbara?
Looks good. Thank you.
Okay, so we'll use those as our working document for the definitions, and then on the principles, if we can go to the next one, Diane. Next slide. Oh, sorry. So again, I tried to, some of this had to be slightly reworded in order to get people in there. And then in number 4, I included the healthcare providers on that one, as Donna had suggested. So any additional thoughts on those?
So I just wanted to say, and I sent you a report this morning, that this morning I sent Lenny and Diana 200-page report. Have you had a chance to read that?
I think I told you that I wanted you to tell me about it on the phone on your drive
from Bethesda. But it also provides guidance on principles for consumer and community engagement. And so I've offered to read that report and summarize it and bring it so we can decide if we want to supplement or augment this with any of the principles from the other report.
Right. I venture to guess there's a huge overlapping Venn diagram that will appear, which will be very exciting. But any additional additive information, I'm sure, would be appreciated.
And we can circulate that to the full task force in case they'd like to read it as well.
You all can read it and send me notes. Okay, does that sound good to everybody? Great. So then I wonder if we have added Suzanne to the...
It is 5 minutes early.
Oh, is it?
What we're talking about is Suzanne Schlappman is going to do a quick update on the work of the Consumer Outreach Task Force, is the short name of that one. And there is specifically having some public forums, one of which was in Howard County.
130 people in attendance. I'm really curious to see the composition of the group, who were these people, but they said it was really successful.
I attended it. That's very good.
And tell us about it. Tell us yours.
I did attend. It was really good. I think John Comer's made a really good presentation of the new system, and my sense from the questions as persons identified themselves, that there were quite a few people in the group that were, what shall I say, consumer advocates or providers. I don't think as many general consumers, but I thought it was a really good meeting. They were very engaged. They had a lot of questions. I'm trying to think of, probably took notes. I don't have them with me, but you could see that there was a lot of interest, particularly from providers, in terms of how will it impact their practice, how will it impact, or will certain issues be addressed, such as there was someone interested in maternity-related care. There were those kinds of things that were asked, but they were kind of general and broad, and the sense was, how will this new model impact providers and services and that sort of thing. But I don't have any specifics here, unfortunately.
Was it your impression that this was the first people were hearing about this? Did they seem to have any knowledge about it?
Yes.
They knew nothing.
I don't think they, I mean, some of them may have known about the rate-setting system in general, but I think the new concept and how things are changing, I don't think they knew. I think this was really, it was very, the response was very positive, too, I should say. There was a lot of excitement about, you know, this change, and I think optimism in terms of maybe it will have a really positive impact on their community.
Hillary, you were there, too, right?
Yes, I was, and I think that I very much agree with what Teresa said. I was most intrigued by the makeup of the audience in that it was very much more of a provider group. I was also intrigued of the comments that did come out. There was quite a difference between those that were providers, consumer advocates, versus the one or two who may have actually been consumers. There did seem to be a break in their perceptions and sense of excitement. The comment that stood out to me from an actual consumer who was actually a caregiver was definitely one of concern. So and it's a very small sample to base things on, but it seems that consumers will be looking for ways to interact, and that there is there's a sense of concern that I think some of these changes can address among consumers. So they'll be hungry for chances to engage.
So the concern was around how care will change, or around the issue of engagement, or what was the concern about?
More around the issue of engagement, and certainly consumers don't have the same level of depth of understanding about the way all of the different mechanisms in the healthcare delivery system work, and that came out in the couple of consumer comments that there were. So questions about how is this going to impact my ability to care for my loved one? Barriers to engaging with the system or getting information, those kinds of things came up. And some of what's in the new all-payer model will make it easier, and some may still have challenges. So that our work is cut out for us in that sense.
I think it was behavioral health. Weren't there was some extensive discussion and questions surrounding behavioral health, substance abuse, and I think it was pediatrics. There was one provider that really focused. I can't remember the specific issue with pediatrics. It wasn't maternity, but it was pediatrics.
Yeah, I do recall
can't remember
that.
What our concern was.
I think that her concern was one of the data sharing, and the same with some of the behavioral health folks, thinking about as hospitals are working with providers and sharing information about patient encounters, how's the data going to move? That particular person, I think, had a concern that CRISP wasn't being used effectively to engage her practice. But I also heard others say that CRISP was being used effectively. So, and then there was also the caregiver specifically who was saying, I can't get the information on the person that I am looking after to help with their experience of care, that wing in the AAA.
So it was CRISP that came up. So that's the Chesapeake Regional Information System for our patients, State Health Information Exchange. Who are, I'm just curious, users of that here as providers? Are you all, Michelle, does your group interact with that? I know the Coordinating Center, Karen Ann's group does.
Health Department.
Yeah. And how about Keswick? You all use CRISP? You do? Okay. I'm sure University of Maryland does, yeah.
And let me just add that if you recall back to the last meeting and Suzanne's presentation on the focus groups, that data sharing was a real concern among consumers. Yeah.
Okay. I think this is perfect timing. So now Suzanne Schlattman's made time for us today in spite of all the other commitments and meetings that she's had. So we're excited to hear an update. Suzanne, I don't know how long you've been listening, but we were having folks who actually attended the forum in Howard County talk about their take on things and the discussions, and then a little segue into CRISP and who's using it. So with that, I'll just ask if you want to go ahead and provide your update.
Great, yeah, thank you. I'd love to. And it was, I didn't hear all the things that were shared, but I wanted to thank everyone who did share comments just now, and thank you for participating in the forum on the 22nd. We had about 128 people at the forum, and we collected 42 evaluations from those folks. So we did get some analysis of how they felt it went. Overall, it was a very positive response. A lot of people were saying this was the first that they'd heard about it, or had a chance to talk with their leaders in the community of how they were responding to some of these changes and figuring out where they can start building some relationships to get more engaged. While all the presentations were scored as very useful, the most high score, or I guess valued presentation from the evaluations was the presentation from the HSCRC from John Colmers. So that's something that we're definitely carrying forward, looking at making sure that there's ample time for all speakers, but especially some time to work through some of those more complicated policy issues, which is interesting as it relates to the focus groups, where they, a lot of people said that they just wanted to jump into how this health system transformation was working rather than looking retrospectively. But in this particular case, a lot of people really valued that context that was laid. And I think he did a good job of really applying what we learned from the focus groups and how he presented that information. And his slides and minutes from the forum are available on our website at the link that I sent earlier. I felt some questions about that. If anyone has a hard time finding it, please let me know. I'm happy to send it to them directly if that's easiest. But definitely take a look at particularly John Coleman for that handout. We've gone through several rounds of edits so far in what we have, so it's fairly final, but I'm always open to suggestions on how it can be improved. So as we do more edits, it's also going to have to go through another round of reviewers beyond just me, is what I'm trying to say. So I'm happy to take that to the group and take that from and work with that. So I'd love your feedback, and we'll do the best I can to incorporate it all in what we're handing out. It's a work in progress, as are all of these forums. We're learning and trying to apply what we learned from each previous one to the next one, understanding that each region is going to be unique and have different, coming to the table with different resources and questions. So trying to respond to that as well.
And Suzanne, for the materials, I definitely understand what you're saying about the reviews, but is this meant to be the sort of final and full piece, or is this the preliminary concept on what you envision as a suite of materials used in different settings with different people, or is it pretty much this is going to be the fact sheet that will be used at the forum?
This is at least, these forums are preliminary in and of themselves, right? So this is the fact sheet, the preliminary fact sheet for the preliminary forums. As folks who are more interested in get more engaged, there will be more probably materials developed and things like that. We're not envisioning developing a huge suite of materials beyond this. If there is a specific question or concern that keeps coming up, like privacy, there may be, I think that was an example that we were just talking about as something that could be addressed more explicitly in its own piece. I think we're open to that, but that's not planned at the current time.
Thank you.
So this is Lenny. Let me ask one more question that I'm sure others have them. But so I noticed that under the "we want more information," so they're directed to the Healthcare for All Coalition. So what is the coordination that you see with HSCRC or the hospitals, and what resources are with you all, because I know we're all stretched. So I'm just trying to figure out how the conversation is going to go in the future, and how HSCRC and the Hospital Association kind of figure within your construct. Or maybe you can't answer that now, Suzanne, and I'll...
Yeah, that's a little tricky to answer. We definitely have been keeping contact information of people who have reached out to us through that and said that they're much more interested in getting involved. We've been putting them in touch with their local hospital through MHA if there is to figure out if there is an existing structure for them to be more formally engaged. Saying, here's someone who came to the forum who's really excited about, and a couple of the cases, it's been the Faith Community Network. I just wanted to make sure that you guys connected. That's been our venue thus far to keep people engaged and keeping them in our email system for when there are updates to share. But anything beyond that, it's hard to tell until we have additional resources.
Thanks, that's helpful. Mm-hmm. Any other questions? I know you got to run back into that meeting. Okay. Well, thanks, Suzanne, so much for taking the time.
Yeah, thank you. I look forward to, I'll definitely be reviewing everything after this meeting, but I apologize that I'm not able to be there and participate right now.
Great.
All right, have a wonderful day.
Yep. You too. So now we will turn to a presentation from Lynn Quincy, who we are extremely fortunate that she has taken time to join us. She's the director of the Health Value Resource Hub at Consumers Union and wears lots of different hats, including serving as a consumer voice on the National Association of Insurance Commissioners, and in that regard, I will, for all consumer advocates in Maryland, thank her for her help last year in getting the rate review done and having an impact on the rates in Maryland. It really made a difference, so I know we're all appreciative for that. So, and they've been doing great work in the area of identifying how consumers view this big picture of value and so forth. So I thought it would be useful to have her come today. So thank you, Lynn. Turn it over to you.
Very tough button. Okay, thank you very much. I would like to send all the love back to Lenny because she is way too modest when it comes to what the role that she plays with respect to advocacy in Maryland. So thank you so much. So let me start by saying not everyone has heard of Consumers Union, but you have all heard of Consumer Reports, and you probably all subscribe. And Consumers Union is the policy and advocacy arm of Consumer Reports. We consider doing policy and advocacy to be part of our overall mission, which is to keep consumers safe in the marketplace. And one of the things that we have really expanded our work and our focus is to think about cost and value issues. For decades, consumer advocates have worried about getting coverage and getting access to health care for consumers. But we really need to think about the problem that has also been with us for decades, which is health care costs go up at too great a rate, much faster than the rate of inflation. And the evidence is very robust that there is insufficient value in the system. There's too much waste. There's too much patient harm. There's well, not in Maryland so much, but unjustified variation in the prices people are charging, and so on and so forth. So we have gotten a large grant and just really expanded our focus on this issue. And as part of focusing on this issue, we needed, the Consumers Union, needed to understand how to engage consumers. There's actually not a lot of literature on how you engage consumers on these healthcare issues, on the cost and value side of healthcare. So we did a series, we did some work on this, and I'm going to share those findings with you and make probably a feeble stab at relating it to what you're doing here in Maryland, and you can call me back. Where do I point this? Oh, just anywhere? Yeah. Yeah. Okay. Come on. So the premise, the reason we're doing this work is probably, oh, I see it thinks I clicked twice, is very similar to what you're doing here. Consumer support is fundamental for policymaker and regulator action. We know that there's very low public awareness of system problems and the solutions that might improve, that might address those problems, and that can hinder progress on our issues that we care about. And here's the kicker. If you want to increase public awareness, you've got to understand where consumers are starting from. If you don't understand where they're starting from, your efforts will probably be ineffective. Why is it important to understand consumers' attitudes? Consumers can't know everything. No one can. We have cognitive limits on what we can understand on any given topic on any given day. So what we need, if we're going to introduce new information, we need to understand what consumers' starting frame of reference for a topic is. And that is why we conducted the work that I'm going to be describing to you. But let me just set up a little engagement model here. If you introduce new information that overlaps with people's existing frame of reference, they can anchor the new information to something. They're much more likely to believe it, and they're much more likely to act upon it. If you introduce new information that is outside of their frame of reference, maybe far outside, you have greatly diminished the likelihood that they will believe your information or that they will act on it, because it's not anchored to something they already know. It's floating out there. And I will give you one specific example to help bring this home. One of the, in the focus group work that I'm going to be describing, one of the pieces of information we introduced to consumers was the fact that healthcare quality in other countries is lower cost and it's of equal or better quality. Probably everyone in this room believes that to be a true fact, but regular consumers on the ground, that's not what they're thinking about. And consumers refused to believe it. They said, I don't believe that. And we were not going to get any traction with presenting that particular piece of information to consumers. And the reason is it's far outside of their current frame of reference. They think healthcare quality in the United States is very good. They think costs are too high, but they're really not quite sure why they could be so low in other countries. So anyway, you will not meet with success if you introduce information that they can't anchor to information they already have. However, consumers have other frames of reference, and sometimes you can take your new information and anchor it to something that's outside of your frame of reference. And I'm going to give an example of that as I go through this. So maybe you're not using a healthcare frame of reference, but maybe there's something closely related. So that's a little technique that we'll be talking about. So what did we do? Well, first we did a literature review to make sure that we were not reinventing the wheel, and that's available on our website. The key piece of work that I'm going to be speaking from today was a series of focus groups around the country to really do a deep dive with consumers on cost and value issues. And we also did a nationally representative survey that was sort of informed by those focus groups that, for the most part, reinforced what we were already hearing in the focus group. So here are some of the findings. High healthcare costs are top of mind for consumers. If you say, what's one word that describes the U.S. health system, we have not introduce the word cost, they say expensive, money, high cost, or a variation. And there's lots of other research. There's great word pictographs. You've seen them where the big word is how often it shows up, done by other people. It's all the same result. This is a top-of-mind issue for people. And we loved this quote. If you take the U and the S part of the healthcare system and put them, and you overlap them, you get the dollar sign. We just thought that was so clever. That's in Colorado. Now, this is important. Consumers think about costs on two levels. Most of the time, they're thinking about the cost they pay out of pocket. And you'll see, again, a lot of the other research, as was surfaced in our lit review, says the same thing. That's what that's what's in their mind when we say healthcare costs. However, they do have some awareness of system-wide costs. When you're thinking about reforms, when you're thinking about, like, if they've got a greedy doctor in their mind, they're thinking not about the money the doctor's taking from them. They are thinking about those system-wide costs. So they're present some of the time. It depends on what you're speaking of. But their understanding of what these system-wide costs are, how money flows around the system, is very vague. It's very incomplete. So, our work is cut out for us. They have a strong emotion when it comes to healthcare costs. They're very angry. They feel that there's a lot of greed in the system, that it's a moral issue, that a lot of the providers are gougers, that there's a lot of arbitrariness in the system, and that it's not fair to consumers. You'll see these sentiments expressed over and over again. Let's quickly talk about quality, though, because we, in this room, we care about getting value to consumers. Quality is not top of mind. If you ask an open-ended question to consumers about what do you think of when I say the words healthcare quality, they're going to talk about the first thing they think of is their own doctor and the office staff. And they're thinking about the softer side of a practice. What is the communication style of the staff? Are they friendly? Are they competent? What was the communication style of the doctor? Does he listen to me? Does he make me feel valued? And it's that whole experience of being in the doctor's office and feeling like they got their questions answered, that they were valued, that is in their mind when they are thinking about healthcare quality. Some of the things that we measure or talk about are not in their mind. The technical proficiency of the doctor, does he follow evidence-based guidelines? Does the hospital follow evidence-based guidelines? They care about that, but they assume, falsely, that that's very uniform. This person is a doctor. They have an advanced degree. Of course they follow the evidence-based guidelines. It's not that it's not important. They expect it to be there, but they're not thinking about it because they don't understand the variation that exists in healthcare quality. And it probably won't surprise you to learn they are oblivious as to the things we use to measure quality: hospital infection rates, adherence to evidence-based protocols, HEDIS, CAPS, and so on. So accreditation, this is all foreign language to them. It is not in their frame of reference at all. Affordability concerns trump quality concerns, and the national, just sort of to get a, weigh the two together. In our nationally representative survey, we asked them to give grades to the healthcare system along certain dimensions. Overall quality of care, keeping in mind how they think about quality, got a B, whereas fairness and affordability got a C. So it's, again, affordability is the key issue for them, cost. I'm going to wrap, this is all going to get married together, but first let's talk about what motivates consumers to act. And I want to actually pause here. When you want to engage consumers, typically it's because you want them to do something. It is not that you just, in a vague sense, want them to be better informed, or in a vague sense you want them to be educated. To engage means they're taking an action, they're interacting with you, they're going off and doing something. And I think that you have to have that in mind as you think about your consumer engagement work, as you use results like this to inform your work. And I'll come back to that a little bit at the end, but I hope that you'll keep that in your mind, that it is, you've set yourself up to fail if there's nothing for consumers to do after you've engaged them. So, so let's turn to my topic at hand. What motivates consumers to act? Well, you need an emotional response to information, and that emotional response is important. The information also must be from a trusted source. The information can't be logical. If it's logical, then it doesn't get that emotional response, and they're not likely to act. It has to conform to their current beliefs and perceptions or be anchored to other information they know. That's a point I made earlier. And local information, because we tested both sort of some statistics about the nation as a whole as well as some information about local hospital prices. Local information is very motivating. And you have to give them something to do. If you engage them, let's say you've provided a very compelling statistic and they're fired up and there's nothing for them to do, frankly, you're going to piss them off. They're going to be very angry. So you've got to think in those terms. Visual information is particularly motivating. For many people, this handout has a lot of text on it. That is not ideal. It is, all right, yes, I'll let Tiffany carry the ball there. Infographics combine data and visuals in a way that reveals relationships and significance much more quickly than pure verbal or pure text information. So, what we did, I'll back up for a second. In our focus group work, we started on our topics with just conversationally. There were no visuals. But we then introduced visuals, and we did different combinations of things to kind of see. But it will not surprise you that the visual information sparked everybody. It served all by itself to engage them much more. And we have a whole bunch of visuals that came out of this work. I'm just going to show you a couple and talk about them. So this is an example of an infographic that was highly motivating that you can't use here in Maryland because you have all-payer hospital rate setting. We actually did some focus groups in Maryland. We used the hospital price variation from a different state because it was too boring to introduce it from Maryland. So kudos. I mean, I want all states to become Maryland, but you need to pick a different provider. So this information was very, very motivating to consumers for several reasons. They were not expecting to see this variation in hospital prices. Because this information is unexpected, it's outside of their frame of reference, the first thing they try to do is explain it away. They're going to say, well, maybe in the St. Louis University Hospital, people were in private rooms more, or they had, and they'll think about, the first time we tested this one, we were in Missouri, so they had familiarity with the local hospitals. So because it was outside their frame of reference, they tried to sort of explain it away, as opposed to attributing it to basically greed, if I can say that. An irrationality in how we price things. However, they quickly, once they got past that, they quickly became pretty motivated to act because they're pretty angry about this and they wanted to know, are there different, maybe the services being provided were actually different, like additional nursing care. And so we had to assure them and figure out how to label the graphic that this is the exact same service, just different prices. So the fact that it was local information was highly motivating. The fact that we highlighted the markup was very motivating because it's huge. And again, it's this instant visual impact. It's huge compared to the baseline cost. And this also elicited a lot of nuanced information about how participants view hospitals. Participants have kind of a complicated relationship with hospitals. They view them as a business. They think This is a business, and they should be able to make a reasonable profit. But they view healthcare as a social good, and they think nobody should be deprived of the right to healthcare when they need it. So they think hospitals should be limited in how much profit they make. You know, it should be reasonable, and that's it. You're done. So if they were to understand the waiver, I think, and the hospital rate setting system in Maryland, they would embrace it, especially when they understand they're kind of lucky to have it compared to other states. This is from the famous article that Brill wrote for Time magazine. He did a deep dive on the cancer drug Rituxan, and he did some, usually you can't get to this information. You have no idea what it costs to manufacture and produce a drug. But Brill, you know, talked to all sorts of people, and he estimated that it costs about $300 to make this cancer drug Rituxan. It's then sold to the hospital for $3,500. The hospital turns around, sells it to the patient for $13,700. This is because consumers, again, of this attitude that we had already elicited about being able to make a reasonable profit, we showed them what a 20% profit would be over and above the cost to acquire the drug or make the drug, and then what the remaining profit was. Needless to say, they were extremely angry about this information. They felt it was very motivating, and much more so. We did a couple other tests in our full report. You can see them of some low-cost things, like we showed the markup on a bag of saline or the markup on a Tylenol pill. Even though in percentage terms those markups were just as high, they were much angrier about this for two reasons. One, the dollars involved were much larger and therefore much harder for the patient to bear. And also it's a cancer example, and cancer is very emotional in and of itself. So even though this type of information is highly motivated, when you're talking about a high-cost thing and you're talking about cancer, that has a much greater response than a bag of saline or a Tylenol pill. So we also wanted to learn, what are consumers willing to do? Because we want to engage them in this area, because we want to engage policymakers in this area of improving healthcare value for consumers. So first of all, they do want to take action, especially when you're talking about cost and patient safety, which was, I'm going to come back to that, which was an exception kind of in where the quality wasn't highly motivating. They need to be told they want to be told what to do. They don't want to have to figure it out for themselves. You know, you don't want this vague message, go take action, let's work together. They want to be specifically told, if you have a bad experience at a hospital, go and register it on this website. You know, give them something to do, and that will be aggregated by your regulator, and it will in turn change how we regulate hospitals next year. That's the kind of thing they want to be told to do. Interesting, they are very willing to take personal actions. They feel that it is not all the government's responsibility, that there is a personal responsibility component, and that's one of the things that they're being willing to take. Particularly, they're very interested in informed shopping. They said, right now we don't feel that the information exists to allow us to differentiate by value across hospitals or other types of providers, even health plans. But if that trusted information existed from a trusted source, it was validated by a third party, you know, all the things consumers want, we would act on it. We would use that to shop, and we wouldn't mind being told, go and, you know, be an informed shopper. But right now they don't have the information. They also would take system-directed actions, you know, like writing to a legislator or weighing in on an action, those sorts of things. However, they're very cognizant of the fact that if they operate alone, they're likely to have no impact. And what they really want is to be banded together into a collective voice where they're amplified and something happens. So, you know, basically they don't want to act and have nothing come of it. Their busy lives, you know, they've got to change the laundry and do the grocery shopping, and, you know, their time is valuable. We were very interested as advocates what system-level interventions would consumers support. This was very interesting to us and unexpected, came out in both the focus groups and the survey. They would support a really broad range of interventions based on kind of where they're coming from on healthcare costs, including price caps, provider payment reform. They would support global budgets, so a little bit different than the findings that were here in Maryland. And we didn't do a deep dive. You know, we just sort of threw out ideas and said, what do you think of these? And, you know, they were all for it. The disclosure of fair prices, so it's not a disclosing what is the price, it's disclosing a benchmark price. It says, this is what it would be if, you looked at the cost to produce it plus a fair markup. Mandatory upfront cost estimates. The few things where they were not as inclined to support it is rewarding providers for good behavior. They were in support of penalties, and we see this in the work of other researchers. They feel that it is providers' job to do a good job, and they should not be rewarded for doing what their job is, and they felt pretty strongly about that. So that's kind of an exception to this long laundry list of things they would support. When it comes to talking about delivery system reform, so you'll notice those other things had to do with managing the prices that consumers were facing. Things like electronic health records and things designed to improve the coordination of care. This is a lot harder to get consumers excited about. These types of improvements seem logical to them. Of course, care should be coordinated. Of course, providers should be technically proficient. Of course, electronic health records are more efficient. It just seems like, of course, you should do these things. I don't need to get involved because it's self-evident these things need to happen. So they're not as tempted to act on these types of things where the need for it seems so logical, so common sense. It doesn't seem like they should have to get involved. There is an exception, and that has to do broadly with patient safety. And we did a drill down here with respect to hospital infections. So people don't realize that how common medical harm is. They're shocked to learn. And we were able to introduce this information that is outside of their frame of reference by anchoring it to drunk driving deaths. They're familiar with drunk driving deaths. They feel that this is a big source of pain and agony for families. It's too common. It's a problem that needs to be addressed. So to show them this infographic where it's people are killed by hospital infections at 7 times the rate of drunk driving deaths, now they're anchored. They've been anchored by that drunk driving death comparison. They are willing to take on this information and believe it, and of course they want to act on it. So this is how we successfully introduced new information that was outside of that frame of reference. So while quality in general, it's a little bit hard to get them excited. Health system transformation in general, it's hard to get them excited. When you are coming at them through this patient safety lens, this medical harm lens, you've got them. You can engage these people. And it shouldn't be surprising. Obviously, this is completely unacceptable, and the only reason it exists is it's under the radar for people. So the bottom line is consumers actually are highly motivated to act. If you approach them with some of the messages I've talked about, that are the motivating messages, they're easily motivated to do something about excessively high costs and high rates of hospital infections. It's harder to get support, so that this is like a generic, they don't really need the drill down on specifics. We're going to stop hospitals from charging this amount for this DRG. They don't care about that. They kind of just need to feel like at the broad system level, they're doing something to help, and obviously a narrowly focused targeted action is going to be best. And you do want to avoid the short list of reforms that don't resonate with them, like the rewarding good doctors things. It's not that you can't enact those policies, just don't pick it as your point of consumer engagement. I'm just going to quickly preview some of the other infographics we did so you can see them. This is, and we can go out to the website if there's time and interest to look at them more closely. But let me stop. Well, and then I can offer just a couple thoughts for you that are specific to Maryland that you should feel very free to push back on, because I may be barking up the wrong tree. Obviously, I think it has surfaced inside of your conversations and focus group work to date that the high rates of readmissions is a key way that you can engage consumers on this. And we saw that the patient safety spectrum generally. Yeah, you can find it. Yeah. And, and I think you would have to anchor it to these are inappropriate readmissions. This is pain and suffering that should not have occurred. But I think that is one way to talk with consumers about the waiver, which I don't think you should consider it as talking about the waiver. I think it should just be a highly focused way of engaging consumers around a specific thing where there is an action for them to take. And I would call yourselves done. Lowering cost, which I know is not the, kind of what you emphasize in a lot of the work around the waiver, but let's face it, that is the point where you engage consumers. They really want to know that their costs are going to be lower. Many insured consumers obviously will hit their out-of-pocket maximum before they pay the full hospital bill, but we talked with them about how that in turn, like when the insurer pays excessive costs on your behalf, in fact, let's fire up this exact infographic. That it in turn makes your premiums higher. And this is hard for consumers to understand. So we had a lot of iterations of this infographic, which is designed to sort of show a circle, the fact that insurers are covering a pool of people. They all go and get medical care. That's sort of pooled together, and then the result, after you layer on some profit, is what your premium is next year. And the point we were trying to make with this sort of circular infographic is that it still matters when you go to an expensive provider because it shows up in your healthcare premium. And they got it. It's hard. It's a lift, but they did get it when we worked with them. So it may be, I think this is more appropriate for like face-to-face meetings. I don't think you could, you could certainly say it, but I don't think you could use this infographic as a standalone thing that consumers are expected to figure out what it means vis-a-vis the waiver on their own. The fact that hospitals are being watchdogged, that there's an agency out there ensuring high value for consumers on consumers' behalf, should be a point that would resonate very well with them. Consumers want that. They can't do it on their own. They can't be expected to do it on their own. Be very careful of your messenger. Hospitals are not a particularly trusted messenger. They're not as bad as insurers or drug companies. But you might, I heard Suzanne before. It sounded like she was saying if an actual consumer expressed an interest in engaging, she was going to then send them to the hospital in the hopes that the hospital had a way of engaging that consumer. It doesn't sound like a good plan to me. I won't do a deep dive on this, but consider who is your messenger here. That's always extremely important. And consumers would really like to have kind of a single messenger as opposed to have to figure it out on their own. Something else to consider is that I've heard in the 2 meetings I've been in that you're engaging consumers on, kind of in focus groups, in these town hall type of forums. However, I think you're going to get a lot more traction if you do your engagement in more of a just-in-time fashion. They're in the hospital, and they're talking to hospital providers. They're talking to the billing clerks or whoever. What can you do at that point to engage them in your waiver process once you've figured out something for them to do? Because now you've got their attention. You're not taking them away from cooking dinner or something they would otherwise be doing. In addition, I think a key way for you to get feedback is to beef up your consumer complaint system. People typically don't even know they have a Department of Insurance, and I'm sure they don't know they have a Healthcare Cost Review Commission. But they often have bad experiences, and their complaint kind of goes into the ether. It is not captured. It is not used for continuous quality improvement. Another thing that we're just in the very beginning throes of, but is to work with states all around the country to do a much better job of capturing consumer complaints. Know a friendly venue for getting them submitted, for capturing them, a way of letting consumers know your complaint matters. We're going to act on this. It's going to result on an action by your regulator. Right now, none of that, consumers assume none of that happens. And they reach out to us because they're so frustrated. So I'm going to stop there and ask for questions. I don't know where we are on timing, but those are my thoughts.
No. Wonderful presentation. Will you join my performance measurement work group? But that perspective is important. And surprisingly, I think there's a lot of people who are enlightened about these issues and for which they are passionate, even as they're hospital providers. And they're on the team with us, and but so much has to get done. The surface hasn't been scratched. I agree. So we've had one consumer call in the 5 years. We put infection rates up because the lady was having a hysterectomy, and we published hospital infection rates, and there was a gap because of a data glitch. And she wanted updated data because she was going in a month, and I had to refer to her doctor to ask about the hospital's infection rates because I wasn't in a position, but by and large, we don't get those kinds of phone calls. So, and you want to talk to what, as a regulator, this is fascinating, just fascinating.
We do get calls in response to our what's now called the Healthcare Quality Reports at the website, but it was the Hospital Performance Evaluation Guide. And, I mean, infections is one area where there was most interest. You're right. We did get those kinds of questions. We know there's a need for that, and it's a need to present it in a way where it's understood. But I also think that, and what you mentioned, the patient experience and finding out what other patients, consumers perceive from their experience, the HCAHPS, the CAHPS data, is real important if it's presented very simply. So those are two areas where I think there's a real demand for information like that.
So let me give kudos to Teresa for putting file a complaint on the up front on the new website, and I'm sure we've all identified this complaints process as a challenge, which is actually why it's sort of our second charge. So we're going to talk about that a little bit more today. But questions for Lynn?
Thank you for that. Can you give us some more of the basics, if you will, of this survey, the sample size, the time frame, how long it lasted, when it was, how you defined healthcare? Was it hospitals only? Was it something broader?
Sure. So the work took place the first 9 months of 2014. We did the lit review first, obviously. We did the focus groups in, and all this is publicly available on the website, so you can go to it. We did the focus groups in Colorado, St. Louis, Bethesda. I think that was it. I didn't go back to refresh my memory. There may have been a fourth city. I'm sort of scrambling to try to remember. And we didn't, within the focus groups, we always started with open-ended questions because we wanted to know, you know, when we say the word healthcare system, what do you think that word means? Or when we say healthcare quality, what do you think that word means? That's part of getting, understanding their frame of reference. So for the most part, and then obviously you can only keep that up for so long because you start talking about it and you start sort of honing exactly what it is you're talking about. We were not using strict definitions. The one thing we did is we stayed away from Obamacare because it's a distraction. You know, people would like to talk about Obamacare, but what we did is we said, we'd like to talk about the healthcare system before Obamacare was put in place. You know, we just needed to remove that, otherwise we would have spent all our time talking about that. But that's about it in terms of kind of putting guide rails on what we talked about.
I'm really intrigued that Bethesda was one of the jurisdictions. Did you screen for the differential that you might have gotten in Bethesda versus the others, since we do have rate regulation here in Maryland? If cost was such an issue, I'm just wondering, was there a differential from the respondents in Bethesda versus elsewhere?
No, and in the rounds of focus group work I've done over the years, I've almost never seen geographic differences. I think states have a little bit of a false sense of how unique they are. I mean, for the consumer on the ground, I mean, a $35 copay could be a high bill. So the rate review in Maryland doesn't feel, it's not top of mind or present for Maryland consumers. Now, as I already mentioned, when we showed them a graphic of the Maryland hospitals, that elicited no response whatsoever because payments to hospitals are so much more uniform. So we then said, well, what about this one, you know, where we showed one for Virginia, where it looks more like the St. Louis one I showed you. In other words, so we talked about what we wanted, part of our exercise was to find out what's motivating consumers. What is that point of engagement? The one difference with Maryland is because you don't have the variation in hospital prices for a given DRG that you see in other states, that was the difference that was less motivating. not because Maryland people are different, but because the facts on the ground are different.
And I understand exactly what you said, but let me tell you why I'm having trouble with that. I feel like I'm the only hospital spokesperson here, and I'm trying to.
Gary's, he's somewhere out there in the cyberspace.
So I'm very concerned about the premise or foundation on which we make this an adversarial scenario between consumers and hospitals, not just providers or the system, but hospitals. So if in order to evoke that kind of response, you got a no response on Maryland hospitals, we went to Virginia to try to evoke a response, then it seems to me we are artificially manufacturing and setting ourselves up for something in Maryland, or heading, and maybe I'm being too sensitive about this, but heading down a path that is not necessarily productive. And as a global construct, I'm concerned because I think in order for the waiver to be successful, hospitals clearly are a part of that, but they're not the only part of that. And so to begin to think about setting up a driver for individual response that's based upon something which is not the same in Maryland as it is elsewhere takes us in a direction I would not like us to go.
And if I can be clearer, it's not a recommendation from me that you substitute in Virginia prices. This exercise is designed to reveal two things. What is the consumer's starting place? Because wherever you want to go with them, I was just trying to make the point in the beginning, you've got to understand where they're starting from. You know, a very honest, wide-eyed look at where they're starting from. And then the second thing is, if you want them to take an action, and I hope that you will, you've got to understand what motivates them to act and what doesn't motivate them to act. So I would agree with you. We wouldn't want to be adversarial, and we certainly wouldn't want to make them feel worse about hospitals than they are to start. But it would be good for you to, like, to the extent hospitals are not the most trusted messenger, that's important to know in terms of being effective. Hillary?
I very much get what both of you are saying, and thank you, Lynn, for a fabulous presentation. Donna, your comment went to some of the questions I had, the first being all of the examples, not just the infection rate one, but all of the examples that you gave in the presentation were sort of anger-based motivations. And I wonder if in the focus groups anything came up in those discussions that was more of a positive spin that it may not have been as strong as the anger-based motivations and therefore didn't make it into the presentation, but that it was part of the discussion. And then the other question that I wonder from the group, because I don't have the answer to this, is to what extent do Marylanders interact with hospital systems across state lines? I know that in Montgomery and Prince George's counties that happens a lot, but I don't know about other parts of the state. And there may be something in that we can say, hey, look how great the Maryland hospitals are doing by comparison. This is why get involved in this process.
Right. Can I just, that last one? On all of our borders you have that, so Prince George's and Montgomery going into the district, in Western Maryland going into West Virginia, on the Eastern Shore going into Delaware, and in the northern part of the county going up to, the state going up to Christiana, also Delaware. So that is an interesting thought.
So consumers, there are things that they feel positively about. They tend to feel good about their personal doctor. Some of them assume a very high level of quality in the U.S. health system. I have to say that's typically the people who haven't used the health system. Among the subgroup that has had an experience, a big experience with the health system, a lot of them have more of a mixed feeling. They feel like there's good parts and bad parts. But the predominant emotion is extreme anxiety about being able to afford health care. And there is this ubiquitous, if perhaps undeserved, sentiment. And it is not just our work. You can see this in Gallup polls, Harris polls, the focus group work of others, that there are some villains. There's real villains out there. I think somewhat incorrectly, health insurance plans are perceived as terrible villains. Drug companies are perceived as terrible villains. Sometimes medical device companies, sometimes hospitals, sometimes specialists. Typically that primary care doctor that you go to, he gets to wear the white hat. I'm just reporting out, again, where we're starting from. It's, you know, this is a terrible source of anxiety for consumers. And they're very, it's a top of mind thing. And in about 25% of consumers, this is the financial question that worries them. Not getting a job, not losing their job, paying for health care.
So again, I'd like to thank you for your presentation. And it really, some people probably would call me a health literacy zealot. I love health literacy and making sure that information is presented to the public in plain language, and the principles that you addressed in your, or that emerged from your studies, just mirror all of the health literacy principles, strategies. Everything that we talk about in health literacy is reflected here. So I think that as we move forward, we just have to think, you know, this is your organization's support of this, and we also have all these data, years and years of health literacy research that say information has to be actionable. People don't care if they're not acting on it. And so when I looked at the flyer, it's pretty, and the colors are nice, and the font is lovely, but there are a lot of words there, and there isn't a really clear action that's being requested. And so as we move forward, and Barbara's nodding her head, I've converted a lot of her staff through my workshops because there's this really neat tool that the federal government has released called the PMAT, and I can't think of what the acronym is, but it's a little tool that helps you to read any educational materials or any public consumption materials that you have and assign a grade to it. And one of the sections is, how actionable is it? Is it clear what you want people to do? So I trained in health literacy, and I'm happy to speak at a future meeting about it. I just review the PMAT because it applies to the materials that we'll be producing it, and there's a video version, but there are a lot of resources out there that can help us to make sure that we adhere to the things that you've shared today. So thank you very much.
Lynn, this is Gary Vogan. I'd like to thank you for working on this and for sharing your knowledge with us. It is important for us to be able to understand the framework in which people will take this in and act. It's particularly challenging given all of the technical issues, and I do engage with Donna on the understandability of things like price when used in an environment where price is not payment, and other complexities. And it reflects the kind of challenge that I think we have when we talk about explaining a very complex system and motivating engagement by the people who benefit from the system and pay for the system. And the complexity starts with the idea that unlike many of our things that we believe are social rights, we don't have a social program for healthcare. We have a quasi-social program that runs through a for-profit environment kind of an approach, and that makes life very difficult to explain.
I wonder, though, is it necessary to explain the intricacies of our system to consumers? I mean, what have we gained? My recommendation to this group would be to decide very precisely what is it you want consumers to do and work backwards from there. And probably, hopefully, that will result in only needing to explain a little part of the system. As a consumer advocate, I'm fine with that. People have busy lives. I think we have to be strategic about which part of their lives we seek to go in and claim.
I would have to agree with that. And I think that Lynn's point about anchoring new information to something that people know is particularly important. You get to talking about a waiver, and unless you do this 24/7, your eyes glaze over. You have no idea what this is. But a simpler description, and we talked about this a little bit the last time. Maryland has a unique something, whatever we call it. The word unique is attractive. They know it's now different. There's some pride in that. It's a positive angle in terms of talking to the public. But to get beyond that and get into the weeds, people will say, I don't know what they're talking about, and moreover, I don't want to know what they're talking about.
just to piggyback on what's been said, so the note that I wrote to myself is timing. Does this community engagement effort or consumer engagement effort inform what the hospitals do, or should we react to, like you said, like we need to know what we want consumers to do, whether we have a signature initiative or some type of campaign that then we can educate the consumer. But right now it's very abstract, similar to the comments that I made at our last meeting. Like, what do we want folks to do? And are we maybe a little early in this effort because we're really not clear on that? Or should this effort inform how the hospitals begin to make this more real to the community?
So that's a question.
Yeah, or statement, question.
Well, I guess I don't have an answer because I'm not clear on how you'll measure success. In 2 years, you'll look at what consumers have done and what will represent success. If I can riff a little bit on something that Donna just said, I do think, so again, I don't have the objective in mind, but I feel like messages such as you were teeing up, Maryland is a leader in how they work with their hospitals. Hospitals and regulators in Maryland, unlike a lot of other states, we formed a partnership, and it's going to result in better care for patients compared to other states. I don't know if that gets you to your end goal, but I do think those are messages that would resonate very well.
And this is Lenny for those on the phone. We need to identify those measurements for success, which we discussed briefly at the last meeting, and which I know HSCRC is working on. And as you may recall from the last meeting, we agreed to pull a smaller group together to address some of these questions. I think this question of timing is absolutely critical, but maybe we need to better understand how we're going to measure success in order to identify what that point of timing is and what that call to action is. But I like the idea, too, of I think we just have to keep the call to action. I'm going to put it up right above my computer and hope it doesn't crash before then. So we'll talk about that later. The other point I wanted to raise, too, again, just to go back to your point, which is really underscored in everything you've said and done, is this idea that informed consumers, knowing their rights, are enabled to make complaints or grievances or appeals, but that the information from that, part of that is what drives the policy and the advocacy agenda, that they're commingled. And I think that that's part of what we were trying to put into the second charge for this work group, which we'll discuss later in more detail. Yes. Okay, go ahead. On the phone.
Doug Rose.
Doug Rose. Hi, Doug.
Hi. First time I was in it,
we're having a hard time hearing you. Doug, can you
sorry, is that better?
Oh,
yeah.
Can you hear me now?
Yep,
okay.
Hear you now.
I guess I'm here to represent consumers to some extent, and I have to say, like, as a consumer, my first priority, my number one priority in accessing health care is getting the best possible care for my condition. And by best possible care, I mean the best possible outcome. I'm a person living with HIV, and when I came to Baltimore, I was in the advanced stages of AIDS, and I needed the best possible care to save my life. I shopped around. I didn't shop around for who I could afford. I shopped around for who could give me the best. And Johns Hopkins, I felt, could give me the best, and that's where I went. I have a friend at University of Maryland now who has cancer. And it's a rare and exotic form of cancer, and she is concerned about whether she's getting the best possible care at University of Maryland. So what she is doing is she's shopping around, and she is looking at ratings of other hospitals and other cancer centers. And what she has discovered is, in her mind, Hopkins might be a better possibility. The best in the country would be a hospital in Texas. She's trying to get a second opinion from Hopkins. And the doctors at University of Maryland are going berserk because they don't want her to leave their system. They say, oh, we'll give you perfectly good care here. You don't need to go to Hopkins. You don't need a second opinion, et cetera, et cetera. Her only concern is that she find the medical care that will save her life. That's it. Now, in terms of these questions of cost, what I'm wondering is, first of all, it's incredibly difficult for a consumer to understand anything about cost. I get my explanation of benefits on all the health care I get, and it's crazy. I have no idea what this means. The hospital charges one thing, then Medicare pays a certain amount, and then my insurance company says, well, if Medicare pays that amount, then that's all it's worth, and it goes round and round, and I never quite figure out, how much did that service really cost? And when I saw that chart comparing costs among different hospitals, and I know in Maryland that's, we do it differently here, but the reality is the actual, what the hospitals actually receive on any given service is very different from what they actually charge for any given service, and those costs change according to insurer and whatever the negotiated rates are and all of that stuff. So, when you talk about cost for consumers, it's really hard to wrap your head around anything bigger than how much is the check I am going to have to write. And that is borne out in a lot of the stuff we've seen today. I just don't know how you can ask consumers to think about their health care in terms of cost to the system, because it's nearly impossible to help consumers understand how those costs are even identified. So, I wouldn't know, is it better for the system for me to go to this hospital than that hospital? I don't care about that. I don't care what is better for the system. I want to go to the hospital that is going to give me the best care. And so I understand why we want to try to do this, but it's a really heavy lift, And the other thing that's happening is with ACA, I'm hearing from a lot of consumers that, this is not saving money. Previously, I didn't buy insurance, and I walked into a hospital, and I got care, and it got paid for somehow, and it didn't cost me anything. Now I'm having to pay a premium, and I'm having to pay co-pays, and I'm having to pay an awful lot of stuff. And I'm not saving any money. This is costing me money.
Yeah, Doug, I think that's one reason why we're separating this from Obamacare, right? Because that is an Obamacare ACA issue of the mandate for everybody to have insurance versus this charge. But I don't, do you want to respond to anything, Doug's point?
Well, I agree with everything he's saying. That's why you may want to consider, as a point of consumer engagement, the infographic that's still up on the screen, helping consumers to understand that you are protected from a high bill by your insurance, but it comes back to haunt you, and that's why you should care. Which, as I said before, this type of information is workable, but it's a big lift. And I do think that as you engage consumers, separating it from Obamacare would be very useful to you. There's no good reason to marry the two things up. So,
and Lynn, I know we need to let you go, but is this kind of work happening is what we're trying to do, albeit it's within the waiver as opposed to the value, the delivery system transformation. I know there are projects going on, but so I think it'd be useful for others to know, specifically on the consumer engagement piece. Are there models that you know of in other states that are doing what we're trying to do?
I would say for the most part, no. I know there are other states who, as part of their SIM grant, are starting. You know, they're where you are. They're trying to figure out how to do this. I know out in Oregon, an advocate that we both know, Jesse O'Brien, is trying to introduce a price transparency bill, and he's going to try to do a big consumer engagement campaign around that bill. And I know in Oregon also that there's certain aspects of policy items that they have tried to engage consumers. But this is very nascent. We don't really know a lot about how to do it, and where is a good investment of our resources? You know, where are we going to get a bang for the buck that you're putting in, including, you know, your human resources, your time.
Barbara. I've really enjoyed this. This is great. It does make logical sense to me, what you've presented. And so what I was wondering with the hospitals in Maryland and what our role is, when I think about it, why we should all be, what's in it for me, why we should all be concerned about Maryland being able to be successful, all the hospitals be successful, is if we're not successful, then what's the alternative? Will we lose the all-payer rate-setting system, and then we will have the experience of those other states and jurisdictions that you showed. And so, you know, for me, I definitely want to avoid that. I and everybody else hasn't appreciated how we have benefited by not having to shop around hospital to hospital. You're pregnant, you're going to be delivering, you don't have to call around to all the hospitals and try to get their estimated charges. And then after the fact, you don't have to think, oh, maybe I should have gone to another hospital because, you know, it would have resulted in less out-of-pocket costs. So, you know, so that's all that I can come up with right now for why might people be interested. Well, to avoid that situation that the other states are experiencing that don't have the all-payer. I mean, why should people care about their local hospital, especially if they don't feel particularly protective of their hospitals? Like in Frederick, we have one hospital, and so it's a little bit easier for me to know people feel very strongly about wanting to keep their community hospital. But in the other jurisdictions where there aren't as many, I mean, where there are many hospitals, people might not feel that and might not have that emotional tie of, oh, I need to do what I can to protect my hospital.
I don't know where we are on time.
Well, I can cut what I say later, so this is so valuable. So
it's just occurred to me listening to you, like yet a kind of another angle on what you're doing. You do have this time frame, which it creates this sense of urgency, which I think enhances your opportunity for engaging consumers. What if you sort of talked up, you know, again, I know it's not about cost, but that's what's going to resonate with consumers. We're doing a better job than other states of reining in costs, and we have these spending limits and have like a clock, you know, like the old atomic bomb clock, or some website that is, you know, showing how we're doing vis-a-vis the bar, and it shows the time ticking off. And, you know, we're all in this together. We want to get across the finish line in good shape so that our waiver continues, and we continue to be the best in terms of our hospital partnerships and costs that consumers face. But, I mean, it's kind of this, it made me think of it, what you were saying, this, you know, time is ticking by. We've got the spending limits. How are we doing vis-a-vis this bar that we've set up for ourselves? I don't know if something like that would
I think this is Karen Ann. Just one more thought, and it sort of resonated, or Doug's comments really resonated, that we want to also not just do cost, but also quality. I mean, I'm thinking of that chart where we saw the hospital comparisons, and I know Maryland has the all-payer, but there was nothing that showed me the outcome of the intervention and the success rates vis-a-vis the cost. And I just don't want to lose the quality side of it also.
And this is Doug again. I think the trick is we can tell consumers that, you know, we are keeping costs down, but when the next year rolls around and their insurance rates go up, they're going to say, well, we made the mark. You know, how come my insurance rates went up again when we're doing all this work to save costs?
So then you give them the phone number of the insurance commissioner, and you you get the insurance commissioner to get down on these insurance companies and have them explain exactly where is this increase coming from, you know.
Oh, go ahead.
No, well, you know, in a way, your life, I think, would be easier if it were part of a comprehensive effort to provide value to Maryland consumers, because it's less cognitive work for them to think about only a segment of their health care costs as opposed to the whole package.
Yeah, so on that, Lynn gave me a chance to plug our rate review, which we want to get done this year, right? So, and the carriers put the rates in March. They go to the insurance commissioner. We have a relatively short space of time to analyze those plans. And I'm wondering, actually, if an infographic like this, if this year there's a need to activate consumer advocates on that issue, if something like this to help explain better. So,
well, again, that's like a point of entry. Like I was talking about, you're admitted to the hospital or you have a complaint. You've just gotten your rate increase. You're not happy. Can you have a notice included with that rate increase that says how to complain or how to get involved? And as part of involving them, you know, it's an easier lift, and you can slide this in. You can say, well, the hospital part, you know, we're doing good on that part, something like that. Look for the low-hanging fruit.
Can I ask a point of clarification? Lynn, in your presentation when you talked about the levels of interventions that consumers would support, one of the ones you mentioned was global budgets, and then I think your caveat there was as differentiated from what we saw in Maryland. Is there a study or something? Did I misunderstand that?
Well, I didn't go to the focus groups that Healthcare for All that Suzanne updated us on earlier, but one of the focus groups was the Eastern Shore, and they were primarily women of Medicare age. And when the concept of global budget came up, they didn't want it to affect their ability to get care. So the impact to the individual on a global budget was too hard of a. It didn't fit in the frame of reference. Yes. Right. Yes.
Thanks. Any other do or die questions for Lynn? I know where to find her, and now so did Diane and Tiffany. So she's a Maryland resident, thank goodness. So let me encourage everybody to go online and look at all of the information, because there's much more to be had within the meat of this, and it is really interesting. It's great that one of the focus groups was done in Bethesda, and I was actually just, my thing just open to that interview. So, so Lynn, for everybody, really just want to thank you. That was absolutely terrific and enormously helpful, and we do know where to find you. So, yeah, thank you. So, what we didn't really do, and I'm not sure that we have time to do it today, but is to really talk about, within the context too of what Lynn discussed, talk about a little bit more about the handout for that's been used by Healthcare for All at the forums. I wonder if we might take this to the smaller group, which is going to be meeting, and that group at this point is made up of Hillary and Susan Markley and Gary Vaughan and Michelle Clark. I'm not sure Michelle's not on the call, is she? No.
And Karen Ann volunteered as well.
And Karen Ann volunteered. Thank you, Karen Ann. Great. What is the name of the group? It is Charge One Group. Yes, it's the Charge. In fact, Hillary's already done some work for us. So, so we're going to try and set up a meeting within a week, and perhaps we can then have some further feedback on the Healthcare for All handout that we can share with them. If anybody who's not on that work group or whatever it is wants to join it, let us know. But also, if you can send back feedback to myself and Diane and Tiffany, any thoughts you have on it, that would be helpful, and we can pull all of that together. Does that make sense? Mm-hmm. Yeah. Okay. So I thought we needed to turn and talk a little bit about our second charge, which, as I said in response to Lynn's comments, is really to look at the improving the communication pathways for consumers in the area of consumer protections to make sure that they have the information to know where to go to file an appeal. I think I said last week, we've just done a rather broad environmental scan, and there are 20 or more places to go. We're focused for this purpose more on the hospital side, so that's going to make that task a little bit easier. But what is being provided now to consumers from the hospitals on this issue, and then looking at how can we support their work to improve or expand those materials. Are there any initial thoughts on that? Hillary?
I'd love to understand more about the feedback. Early in the conversation, Diane, you said that you'd only once had any feedback to your line, and if you could give more context as to how long it's been up, what types of information are posted next to the feedback line, etc.
Sure. So what we have on the HSCRC website is data on hospital-acquired conditions or outcomes that are negative that occurred as probably a result of care and not a normal progression of the condition. They're called potentially preventable complications. And by and large, though, the hospitals have improved almost 28% in the last few years from starting year. So in 3 years, I think we've improved from 10, 11, 12, 15, 4 years. There is variation of practice. There's 65 of these complications that are listed, and there's a subset that's infection. So what this consumer found and was worried about was having to have her own surgery in a hospital where she said it was relatively high in her reading compared to other hospitals. The other source of information is what Teresa was talking about, and it seems that they do get a fair number of consumer calls about the data reported. By and large, we're sort of differentiating our roles in terms of regulatory agencies, and we're a huge data shop, and we crunch a lot of data, and the purposes of the data crunching are mostly related to judging the hospital's performance fairly, adjusted for the types of patients that are in the hospitals, so that you don't say a community hospital who has these patients who aren't as sick as ones that go to the academic medical centers, well, their rates of some complication are lower, but you have to adjust for the types of patients they're seeing and who maybe have more risk for those complications anyway, even though we're saying that mostly these things could be preventable. Not every single case, however, because things can happen that are not the, quote, fault of the hospital. So that's the purpose of our work, is to judge hospitals fairly and calibrate the rates they're allowed to charge to the insurers with adjustments that account for how they perform. And so some are process measures, some are those HCAP scores. Maryland as a state doesn't do well on HCAPs. We're sort of poor to middle, I would say. So we're really trying to focus on that. The one area where we are improving is, I knew what to do when I left the hospital, that question, because there's been such a focus on discharge planning and care coordination. And so I give a lot of credit to the hospitals that have rolled up their sleeves and did a ton of work, and it's showing actually in moving a score on HCAP. But on the other questions, it's things like how would you rate your doctor, your nurse, communication. There's a cleanliness, quietness question, those things. So we use all that data to calibrate payments. I talked about readmission reduction. Our readmission rates are high. That can be affected by things like the denominator, how many people are moving into the state, for instance, or moving out. It can raise or lower your rate. How many index admissions? We dropped from, when I first came, 800,000 admissions a year. We're now in the 600-something thousand. So the index admissions are dropping. So readmissions, as a function of a rate measurement, may be affected by that denominator, not that things are going poorly. So there's some measurement noise that we have to account for and appropriately adjust for. There's a lot of concern now about adjusting readmissions for socio-demographic factors, that you must consider some of those things. On one hand, using those is giving hospitals a pass for high readmission rates. That's not right. On the other hand, if you don't adjust for them, how is it fair to hospitals? So we have all these measurement, weird, quirky things that we do in order to get, if you're going to use it for payment, you have to be spot on about as much as you can. Don't let the perfect be the enemy of the good kind of measurement thing. So that all said, that's what we do. And then what Teresa's MHCC does is much more focused on, as she was saying, presenting to the public and having it be user-friendly, consumable, actionable. So they have an effort to do price transparency. Thank you again, Lynn. It was really appreciated. Thank you. Price transparency, and then all of these measurements that I'm talking about. But the hospital-acquired conditions measures, I think Teresa's working on using a tool in the public domain called Monarch. It's M-O-N as in one, and then AHRQ, which is the Agency for Healthcare Research and Quality. They have the ability to pull in lots of measures. They're starting with the measures that are in the public domain that CMS uses, the Joint Commission uses, that AHRQ uses. And then I think there's a capacity to build that and also do some consumer-directed choices in the tool so that they can figure out what they want in this just-in-time approach. So that's sort of a broad brush, short context what we're doing. Yeah, yeah. And then we do from price. My colleague Dennis, he's on the rate setting side. I'm on the methods side, and then there's rate setting, which is literally measure the units, give the price, audit to make sure the price is with the units, like it's counting, bean counting. And Dennis gets a lot of calls from consumers on their bills, and he directs them to the insurance commissioner or back to their payers. So we do people contact us. I don't think it's frequent, but those kinds of calls do come here. We do communicate with the Office of Healthcare Quality, who go out and do visits. They're the deemed arm to do Joint Commission accreditation, site visits, and Medicare certification, survey and certification. So they do on-spot visits from people who contact them. Hospitals have to also report to them serious reportable events like never events, things that are awful, that should never happen. And then there's the office, the legal.
The AG's Health Education and Advocacy Unit. So, and now you've got some appeals coming through the exchange.
So the big thing that I'm hearing from what you just described, Diane, and I think you were getting to this earlier, Lenny, with the environmental scan, is that there are almost too many places to call, and you don't know which one to take. And if you get the wrong one, then you're starting yourself on a wild goose chase down the rabbit hole of being referred here, there, and the next place because you weren't sure who to call in the first place. So I don't know if there's a way, and we're fortunate in that we have a lot of the right people around the table, but
yeah. So it's somewhat amorphous to me to say we have a new model, and I don't know that consumers are going to make a leap about there's a global budget, and we have a new model, and the reason my care is this way is because of that, therefore I'm going to call. Like, I don't see that really ever happening. It has to be something much more concrete and meaningful to the care the person's experiencing, and and action for them to take. I think there's plenty of actions that we just need to be more communicative about what the actions are, and so that they don't get the frustration of not going to the right place to begin with. And we need help with health literacy around that communication.
And Lynn pointed out at the beginning of her discussion that nationally, and I certainly heard it at the conference I was at last week, that there's a cry or a need in many states for a far more centralized call center for consumers. And that's far easier to communicate than the multiple places that they have to go in Maryland. I wonder if, two thoughts I had to respond to both of you maybe, is it possible to share with the committee members just a brief list of where all of those entities are that people go now, such as, I mean, the AG's office, the Health Education Advocacy Unit, they have a very specific piece. The Office of Healthcare Quality has a very specific piece. MHCC has a very specific piece. I wonder if it would be useful for everybody to kind of see that laid out as we think about this other, so there's nodding heads around the table.
Yes, and I'd add for Medicaid enrollees, there's the ombudsman position in every county. And I have to say that I am surprised at the low number of calls from patients and providers. So it's for both patients and providers who are having issues, a variety of issues, access issues, payment issues with the Medicaid system. And to me, it looks like the number of calls that we receive in the Ombudsman Office and the Administrative Care Coordination Units, the ACCU, that the number of calls received each month is low compared to the number of people who are experiencing issues out there. And I know periodically there have been larger community issues that I knew very well that many people were experiencing problems, but yet the individuals and the providers were not taking, even if they were aware of there being a number to call, and even if they thought that we could do something to remedy their situation, people were not calling. And interestingly, then the response from the Medicaid administration was, well, it really must not be a problem because your call volume does not suggest that there is a problem.
So that's a perfect segue. We can come back. We don't have to segue completely, but to the sort of second part of this charge, which is the information that we receive from consumers drives policy changes, right? And if we don't get that information from the consumers, if they don't know where to go, we can't proactively help to improve things. So another example, just like yours, Barbara, and I know I'm going to say specifically the behavioral health community, has gone to the Insurance Administration on a number of occasions on a number of issues, and the answer back is nobody's complaining about it. Well, the process to file a complaint with the MIA, and you know, do all of you know actually what their narrow piece is as opposed to the new exchange or MHC? No. Well, you may. It's so complicated. So I think that these two issues are linked as we think about the sort of breakup of the two charges of the need to get the information to help hospitals improve what they're doing or react to what their patients are saying they need. So one of the barriers is obviously the lack of awareness on the part of consumers of where to go. And I wonder what other barriers you see. But before we get to that, one thought I had was, to go back to what Hillary said, is I wonder if from Teresa we could get a sense of what calls they do get and what those calls are about, some sort of a breakdown on that.
Sure, we could do that. We can. I can characterize the calls with Tiffany, and I could work together with Dennis, who's getting. His are mostly care in the hospital, bills from the hospital. So yeah. So can I give you an example of exactly that that input and response that people don't know probably, but that is there's a double-edged sword here. Mm-hmm. One is HCAP. This consumer experience survey. Like I said, Maryland doesn't perform stellarly on that. So what we have done in the last 2 to 3 years is increase the stakes on that part of the measurement system. And it's now almost half of what we're proposing to be 2% of revenue, hospital inpatient revenue. So half of that, so 1% would be riding on 45%, so it's close to half. So we've ratcheted it up because we see that hospitals aren't. We want the state to do well, and we want individual hospitals to do well. So we've changed the weighting of how much hospitals are going to get paid to reflect the response that we want. But then what you're going to do is go out and tell people. People, by and large, don't like their experience in the hospital, or it's not that they don't like it. They express a negative. They express a less than, a below average compared to the nation experience with communication with doctors, nurses, et cetera. So then we're saying, but the regulators are doing something to change that. So my reticence is is that a success? You know what I'm saying? Yeah.
Diane,
yeah.
I have a question on that. Have we ever looked at whether HCAP scores by state or by location reflect a more skeptical population or a more educated population or other things, as opposed to simply accepting them and buying a bigger whip?
Yes, I get what you're saying, Gary. So there has been a lot of concern over HCAP. The research started in the 90s, I think, early 2000s. CAP scores have been around for health plans since the late 80s. How long? Really, really, really long time. There is a scientific body of research that developed that tool and has been it's been validated. So at the same time, though, we understand that rural hospitals do better on it than urban. Does that reflect people being discontented and in different groupings that we don't understand exactly? I don't know. So there is some issue to what Gary's saying. On the other hand, it's the only thing we have, and it's a standardized instrument, and it is a reflection of the consumer voice. So we cannot just disregard measurement. But also, I happen to know that it was what the development process was, because I piloted that instrument in 3 states in 2002 in the survey modes for a project with ARC and with CMS when I was with the QIO. So I know the work that went into that instrument is what I'm telling you, and how it was developed and how it was validated. So there is some truth in that, but the whole state, we're sort of a representative of the entire nation. We have the 50th of the Medicare budget. We have rural, we have urban, we don't have any critical access hospitals officially, but some of the Eastern Shore ones or out west or whatever, maybe a critical access like. So we have a microcosm of the U.S. and saying that we're just fair, banal. What can I say? Poorly, and we want us to do better on that. And I don't think people here are any different than in the rest of the U.S. I don't.
It did strike me that as we think about all of this messaging, we really do need to think about the contrast between the urban and the rural, because the perception, I know I was at that Eastern Shore focus group, and I, of course, now being of Medicare age and a woman, thought it was by far the most intelligent group because that's who was in the room. And don't take that wrong, Gary and Doug. But it does strike me there's a sense of ownership, which you described, Barbara, in where you've got one hospital as opposed to where you've got a more competitive area. So we may want to be sure that we consider that in all of this. as of now, the barriers to consumers understanding the complaint and appeal process, is it just a basic lack of information? Is it a language thing? Is it a health literacy thing? Or all of those things that play? And what's in your community, Michelle?
I think it's multiple different factors. I think the health literacy is definitely a big issue. Sure. Sorry, the people on the phone. We're recording, so I'll say it again then. You know, at GASA we deal with mostly immigrant communities, mainly the Hispanic community, but several different communities. Health literacy is a major, major factor. Language barriers is always a factor, and also fear of rocking the boat. Fear of complaining and then having, you know, repercussions from having voiced their opinions or had brought something to the attention of authorities. I think that's a really big one, that just getting awareness out there will help to combat.
And then I would add that at the health department, we have received calls from individuals who would like to file a complaint, would like to know the process. And in our trying to figure out for this individual, you know, and a brief understanding of what their situation is, where at the state can they do that, or, you know, or with their providers, that we've had difficulty identifying all of those sources, and we've had a computer and, you know, are somewhat aware. So I think it's, even if individuals, you know, are interested, who they reach out to, it may be that there are very few who, you know individuals or organizations out there that could say, you know, oh, here's this flow map. If your issue is this, if your issue is this, this is the group you can call, this is what you can expect they'll be asking, or this is the limits of what, this is what they can do, these are the limits of what they can do.
Can I ask Donna to weigh in from a hospital perspective? I'm real interested, because I know there's been a lot of effort on the hospital's part to, if there is or when there is something that needs to be aired with a patient or family and the hospital, that hospitals have really stepped up in terms of transparency and apology if something horrible happens, and et cetera. So it's a hard conversation, but I just wanted to ask you.
Apology jarred me. There's a bill, maybe for the 39th time, trying to make apologies possible in a hospital so that there can be a dialogue without plaintiff immediately running to the courthouse and saying there's an admission against him, just now paying me $90 million. So that one hasn't moved. But I do think, I mean, there are ombudsmen and other people, advocates working within the hospital to try to help mediate and address issues that patients may have along the way. And I sometimes hear from some of the people who do that role about how their utilization has gone up exponentially, and this is the medical center that I'm talking about primarily, because that's where I see that the most. I'm physically closer to that hospital, so I see that more. And that they maintain a very respectful level of independence, if you will, from both entities, so that they can be objective and help provide and open information. And the hospitals worked very hard on maintaining their skill level and elevating their presence and ability to talk to people.
Can I follow up with that and ask, is there, how does the patient in the hospital, and I've been one, but I sure don't remember.
How do they know?
How do they know?
I can't answer that because I'm not that close to it.
Yeah.
I'm not sure whether that's information giving at, at admission, or if the request is made. I'm not sure, but it's a fair question, because I did have someone in a different hospital say to me, actually an intern who's working for me now somewhere else, say, I was in at a hospital for 7 years and I never saw an ombudsman, so it's great to know that you all have this kind of a program. So I need to follow up. That was just yesterday, on how does somebody know that that's available.
I think that would be useful for information for us to have. I mean, I had an experience where, not at the University of Maryland Hospital, a hospital unnamed, but which there were some real challenges, right? And my doctor actually told me to write a letter.
Yeah.
So yeah. So who is
Yeah.
who are the advocates?
We do,
Yeah.
and I think many others also have patients' Bill of Rights
Yes.
posted within the hospital, and I haven't read it recently to see if that's one of the things listed with contact information. I know at some point I've seen a little pamphlet that says there's an ombudsman, contact him or her at this number, but I'm not sure when and how that's disseminated.
Yeah, so we can follow up on that language.
Two thoughts. One, thinking about the complexities and issues about, not wanting to rock the boat or not knowing where to go. I think that we can think about that in the context of the healthcare system and where we are, and the regulation systems, which is set up by many different statutes coming into existence over time. So its creation is very disjointed. That may not take us as far as we need to go, but thinking about what Lynn was saying about different frames of reference, it might be a worthwhile exercise to look to the business community, and specifically retail, that has a lot of experience doing customer service, customer relations, and pick up some of the strategies in places where they're quite effective at figuring out streamlined ways to deal with that. Similarly, I think that there is something to consider in terms of the navigation of the complaint system, because if you're complaining about something, it's negative, and you get to a point where you're getting more and more frustrated, I can't find the right person, and you may just give up before you get there. So that could be part of why we're not hearing the complaints, because at some point you're saying, well, is this really, I was angry to start with, and I'm just getting angrier. Is it worth it to keep going down this road? And I don't know the answer to that. We don't really have a way of collecting data on how many people give up. But it's a question to keep in mind.
I have one other question about the patient advisory boards, or whatever they're named, which all hospitals have, I believe. Am I right? Some sort of advisory board upon which patients could sit, or consumer representation?
I think every hospital does that differently. Some have, yes, exactly that, patient advisory boards. Some have subcommittees of their boards that may invite people in. They're all different.
So I'm just thinking, as we think about sort of who are our target audiences, what are those action items, and then taking that to the strategy point at which, if we're looking at the policy piece of this and making sure that consumers have an avenue, then is one of those avenues these boards. So we may want to take a look at what's in place now. Does that make sense to you, John?
Mm-hmm. I think MHA and the Patient Safety Center both were looking at that issue through the lens of patient and family-centered care, having advisory committees of patients.
So we can start with MHA.
Yeah. Yep. Nicole Stalling.
Yep. Any other thoughts on that? Because we need to move on. And
Lenny.
Yes.
This is Susan.
Hi.
Hi. I've just been listening to the issues around complaints and so forth, and HCAN does take care of all of the Baltimore City Medicaid complaints through our ombudsman's program. I actually have numbers around that and how many complaints we received in the fiscal year 14 and how many we've received this first 6 months of this year, and they're actually quite high. So, I think it would be helpful to know, how many we're talking about and what resolutions, how those things come about. I know that we're talking very high level, but it would be helpful to have some kind of framework around that and how the word gets out. I don't know how the system works. I'm new to the system, but how the word gets out about making a complaint for specifically Medicaid. I'm not talking about, the MIA line. But it would be helpful, I think, for the committee to know, how that's being utilized. I mean, even though, we heard anecdotally, well, we don't get very many complaints. Well, what does that mean? What's not very many complaints?
Yeah,
I don't know if that's helpful at all.
Yeah, well, I wonder, Susan, if you might be willing to provide some of that, a breakdown of that data by category so we know what those complaints are in general. And it just occurs to me, I mean, I wonder if there's a difference in consumers' comfort with filing a complaint with somebody like HCAM as opposed to the Maryland Insurance Administration. I mean, if I were in that position, I'd feel a lot more comfortable. So I wonder, there are so many factors here, and we don't have the resources to analyze it all, but we need to know enough to make a, yes.
Right. So
I agree. Yes, I'll try to pull together whatever it is that you need or that you feel like we could use.
That's great.
And the state has that for all jurisdictions for Medicaid, for the ombudsman calls, for providers and patients by category, and then also by insurance company. But they generate that report and just recently issued the report for the first 2 quarters of the year.
Great. Oh, that would be great.
I don't know if the state makes it publicly available. They definitely give each jurisdiction their individual report. But the Medicaid administration, the part of Medicaid that handles the Ombudsman and Administrative Care Coordination Unit, I don't know their structure well enough to tell you where, but Marion Price, here's Price.
Great. All right. So we want to go through correct channels to understand what can be disclosed in a public forum.
Right.
Regardless of what we think should be, we got to make sure we dot the I's and cross the T's.
Right, and maybe they've done research. I mean, it's just my opinion that the number of calls we've received is low compared to my anecdotal conversations with individuals who have experienced problems and weren't aware of the ombudsman, but maybe it's not low, and maybe there is something systematically different in the jurisdiction I'm talking about versus the Baltimore City one. Yeah. But the Medicaid administration may have done research on that, may have done some analysis over the years that we could benefit from in learning what's been effective and less effective.
Great. That's terrific. I think a great start to the conversation. Do you want to do your?
Yes. Yes. So what I'm going to do is just review what was presented at the care coordination meeting. So that's one of those multi-agency groups where on that organizational chart where we think that there's important opportunity for consumer engagement input in terms of what the vision is at this point. So the focus is of this care coordination work group is on clinical improvement and infrastructure. And that infrastructure comes in the flavor of data, and data about what what utilization of services specifically, so that there's an understanding of how to target who needs the most care coordination based on usually historic utilization. We've done our initial model payment model adjustments. Everybody's on a global budget. We have these big goals that we've shared multiple times. Now we got to focus on coordinating and integrating care and improving community-based care to reduce hospitalizations. And that's where all the hospital partners come in terms of the health departments and other community-based providers. And physicians, and not the least. The solution should need to be patient-focused and and need to include approaches that engage and educate consumers on what this care coordination thing is. Partnership with physicians, practitioners, long-term post-acute care, community health, service organizations are critical in being effective in these strategies. So we see that the underpinning of all of this effort is at the bottom, consumer engagement, education, outreach, and then it crosses, it's sort of fundamental as I see this slide. And then on top of that, we have all of these We have an infrastructure thing, the Health Information Exchange in the form of CRISP. We have state improvement process in public health. And we have Medicare care management fee, which is a thing that we think needs to be exploited in terms of providers understanding what it is. And then of course, the new all-payer model. We're in there. But we're only one component, and consumer engagement, education, outreach spans everything underneath there. And then the ACO movement, accountable care organizations, which are also another effort to provide things like medical homes, in addition to those who've already been doing that for a very long time, like Montgomery County. So initial focus is on Medicare from the vision standpoint of this group. The reason for this is that 2/3 of the high needs patients are Medicare, calculated from our data sets. They have high numbers of chronic conditions. Chronic care improvement is essential for patients and also contributes to cost containment if you can control the condition. And Greg's going to make this look nice in a minute. Thanks, Greg. Medicare patients can benefit from care coordination and customer service mechanisms. So that's stuff we've been talking about today, right? And then, so I was worried how this would tie in, but it exactly ties in. And Medicare savings test does require reduction in utilization beyond the national progress. So we need to save 0.5% a year over what the nation's doing if we do it by year. And the same care process that can be used for all other populations, but again, we're going to start with Medicare. So here we see the data, that infographic that Lynn was talking about. So 14% of the people use half of the resources. And a long time ago, the 80-20 rule was established. Everyone knows 20% use 80% of the resources. High utilizers are defined as 3 or more admissions, just for definition purposes. And this is calendar year 12, and we use HSCRC discharge data. Inpatients, it includes inpatient and ER charges and excludes OB. 2/3 of high utilizers in dollars are Medicare or dual, dual being Medicare and Medicaid. High utilizers account for 1/3 of included hospital utilization. So that essentially just includes ER inpatient but excludes obstetrics. So, so these people who have 3 or more admissions or ER visits in a year constitute 1/3 of all hospital utilization.
Can I just ask, Diane, I've seen that slide in another variation that also pulls out the behavioral health and the comorbidity, which is a complicating factor, if I can put it that way, right?
Yeah, it is. So it doesn't say, these aren't my slides.
Right. No,
but,
I'm not.
Yeah, but it's about, they're my colleagues, and if, believe me, if those were excluded, they would say it here. So they're included, just not articulated in terms of what the fact, what the impact is.
Right.
Exactly.
Yeah.
But no, but we do know that it's a huge factor. So opportunity to address common interests across these new or emerging structures, ACOs, medical homes, hospitals all share common interest. I know maybe, Hillary, you wouldn't like that as a primary care provider, but we all do. And of course you know that. Yes, indeed. Medicare has introduced care management fee, and it's not what one would call, what we think somebody might call chump change, let's just say it that way. So, right, if you do the math, 50,000 patients could be $25 million in revenue. Now, when this was presented at the care management work group last Friday, there were some providers that were skeptical about how flush with cash this makes a provider. So I'll be transparent about that. And then there's a New England Journal quote here, 60% may qualify for that $40 a month program, and there's about 800,000 Medicare beneficiaries in Maryland, so that would be 60% of those. Yeah. And we are, most Maryland Medicare patients are in the fee program, and very, very low, maybe 5% in Medicare managed care. What do they call those? Medicare Advantage?
Medicare Advantage.
Okay. So for some reason, it's not. It's not.
Diane?
Yes.
There was
Gary?
a pretty good article on this online just recently, within the last week, that I read, and it had a projection for an average internal medicine practitioner, and it showed the potential for $200,000 in additional revenue for that person. It didn't, however, go into the costs, and there are some substantial requirements to qualify for the $40 a month in terms of time provided and contact and such, even though it's not face-to-face. But I just wanted to mention it because it was a pretty good, and it was on the advisory board newsletter that started tracking it through, and then you went through a couple of different links to get there.
Right. Oh, interesting, Gary. Thank you. Were those costs up front, or are they ongoing sort of fixed costs?
I believe the costs were largely contact time with the patient, with an individual that would be on the staff and supervised by the physician. I can't recall right now, but I was looking at it and thinking it was probably a close call whether this was going to generate much in terms of net revenue after the additional costs, just kind of ballparking it. I think it's a great thing, and if the costs are covered, the advantage to patients and to the physician in knowing that they're taken care of properly probably makes sense. But in terms of casting it as a great revenue opportunity, it may be substantial revenue. It may cost the program a fair amount of money, but it may not generate significant profit for the physician.
Right. Right. So I think that's exactly what some of the input was at the meeting, is my understanding.
And there's also a fair amount of administrative costs associated with this. If my recollection is correct, you have to have the patient sign some type of approval waiver thing to say that they've enrolled in this program with this particular provider. So if they have other providers, that's only one provider.
So they're essentially trying to get them into a managed care environment, which is currently a fee. Right? Okay. So also, again, aligning incentives across providers, like so that there's gain sharing, like with the various providers that touch the patient. Physician is sort of the most immediate with hospitals, but across. So let me hurry up through this. So here there's a resource base. So the smallest number of patients have the highest need at the top of the pyramid, and then that's Group A in the reddish pink. Group B is the orange and light green, and then the darker green is the mostly healthy population where you want to promote and maintain health. So there are levels of priority, if you will. And then we see the number of beneficiaries broken out by these pyramid blocks. So 5% are at the highest, and you would definitely start. Rough estimates of scaling for Medicare in Maryland would start at the top. So if we were to put an infrastructure in place that addresses care coordination need. And then there's, again, focus with the greatest opportunity. Identify patients at high risk for poor outcomes and avoidable utilization. You have to stratify. So here's a ton of data crunching. In light of the fact that these patients are in Medicare, the claims are not wonderful, clean data. So there would be a lot of work involved in figuring out who the people are. And then we're not even talking about who the people want to be found out.
Yeah.
So that's the other side of it. That was posed as a concern, mainly related to people's rights and confidentiality, et cetera. For selected higher risk patients, about that 40,000, the idea would be to perform assessments, develop care plans, provide individualized case management, and respond rapidly to changes in the patient condition. and in order to avoid even more use. And then implement approaches and interventions to reduce and modify risks and integrate care across providers and settings. Monitor outcomes. Simple, right? So high utilizers in Maryland with a large number of admissions are more likely to receive care at multiple places. So if you look at the people at the way bottom who had 20 or more admissions, they're all in multiple hospitals. If you look at the top, the people who've had 3 encounters, about half of them are the same hospital and half are multiple hospitals. And then as you go down the line, the more encounters, the more you're jumping around. So opportunity to accelerate. It has to be care is local, so it has to be regional and local, but also what can we do statewide? So there's got to be multiple prongs of the approach. So we're looking at an RFP to award to a number of regional collaboratives to organize and initiate opportunities regionally. So I didn't know that until I read these slides before I put them in. So.
Well, I'm wondering if that's the BRFA funding, if that's going to go away, but we won't go there yet.
Oh, well, this was post-election, right?
Well, yeah, but the governor just...
Yeah, I know. Yeah, right. Okay. So framework for discussion of potential activities. Let's skip that. Discussion of potential activities. What are the 3 most important activities, and what are the for state, and what might be regional or local? So that's kind of the work that the care coordination will do. And then here's some examples. This one is statewide. Medicare data acquisition, and that's not a small feat. We have been working on this for 2-3 years. Targeting and stratifying all that data, patient attribution to providers is very difficult and where there's lots of providers touching the patient in a congested urban area. Data sharing protocols, the HIPAA issues, data use agreements, patient wants and rights all come into play. And then how do you engage patients in this process in order to get into this care coordination process once you define what it is. And then outcomes data, and so what is the good that's happening of all of this? Presumably we see better care markers, reduced complications. We better see better patient experience scores, and then also reduction in things like readmissions. And then other things are care planning tool that would be standard, learning opportunities, identification of care gaps like in regions or in certain localities, and then integrating information across the providers and settings. And this would be things like collecting selected data like lab results, pharmaceutical data are also very good ways to understand high-risk populations. And then connecting community-based providers, partners. And then examples of regional, you can read down the list. This is more at the point of care, and it's interesting to me that the call center was put at the regional as opposed to the statewide. So all of this is to say, so a lot of these are repeated except for things like the pharmacist and then assistance with ADLs. That's something that really touches the patient, those 2 things. It's important for consumers to understand what the thinking is to react to all of this, I think. Because this is determined, this care coordination effort is determined to be the way that we're, an important way we're going to get the success and to those high-level goals that we want. And then there's got to be an ambulatory care strategy. This was mostly all focused on hospital care and then what happens before and after that. So that's the end of that presentation. And we don't have time to dig in. It's 5 afternoon, and I'm sorry it's sort of I didn't manage the time so well. But at the risk of cutting short good ideas, I just think it's good to put this out there at least to ruminate on it, and then we can have it as a jumping off point to see at the next meeting what people's thinking is, and also see where what input we can give into this process. I think it's really important that that consumers give input into this care coordination work.
So let me ask you about that, because I think I know Adrienne Ellis with the Mental Health Association is on that, and Lori Doyle, I guess, too. So there are some consumer representation on it. But when is their report actually due?
That I'm thinking it might be similar to our time frame, but I'm not sure exactly. It may be a longer trajectory. I'm not sure.
Oh, okay. So because originally I thought it was February, and then it got moved to March. So, but we're talking about, was there going to be an initial report? We can come back to that.
Yeah, I'm off guard right now, so let me. I apologize. So yeah, it seems like they haven't formulated the idea yet. So it may be that what comes out in terms of a report is not a definitive. It's directional as opposed to a definitive.
Right.
Because I don't see how it could be anything else.
So, in fact, it seems to me that the small group can take up some of these issues too in the interim between the meetings.
Right.
I just keep framework.
Right. So, in terms of the next steps, I know there was a February 23rd date we had on mind, but I perhaps mistakenly put the first week in March on our work plan as the next meeting. Is that something that you think is reasonable?
I mean, it's reasonable from my perspective because I think we've got a fair amount of work to do with the subgroup so that we can have a substantive meeting and not everybody gets together just to get together.
Right. So on the subject of the small group, I know Susan Markley said that a week from today is good, and Hillary, you mentioned that was good for you. And so we would ask Karen and Gary and Michelle if they're available. I haven't gotten feedback on that yet.
Okay.
So
well, so we'll hold Friday morning.
Right.
Okay.
So I think that's a good step. I'm having a hip replacement in a week, so I won't be joining you. Well, Friday I might be on the call, but the following Monday. And believe me, I've done homework on the provider. Told him I didn't want him to be the last case of the day because I didn't want fatigue to be a factor. And he looked at me like I had 3 heads, like, how dare you? This was when I had the first one done. So now he knows me, and I just had that in October. So I think we got to strike this from the record.
Yeah, actually, I think that goes to health literacy, and you are actually absolutely entitled to say all those things. We do it all the time.
Yeah, and somebody, I think it was at the Health Action Conference actually, at one delivery system referral, I don't know, but anyway, she was saying that she's getting ready to retire, and she is doing the research on the hospitals within her region. That is part of, that's one of her deciding factors.
Where are you going to go? Right. Where are you going to go?
Sure.
Oh, my husband and I are there, believe me.
Yeah.
Where are we going to live in the not so far future, which I would rather in the future. But anyway, so Tiffany is perfectly up to speed in terms of doing a lot of the management, well, co-management.
I'm not panicking.
With Lenny, and Teresa is, and I feel like I wished I had a faster clip of a pace to keep up with the wonderful work. When Lenny got the award, nothing gets by her, is what.
A lot gets by me.
No. So Teresa is also going to be a person that is sort of, I'm going to hand her the baton, but mostly you the baton. So, well, things will move, and this work continues to be top of mind. I mean, we saw it in the graphic, and most fundamental and important as we move forward in this process. So, okay.
Thanks. So we do have time for public comment, and we have a public.
Yes.
The public?
Is it Novella? Is that your name?
Yeah.
And then was there someone else I thought that was here? She may have left.
Oh. Did you?
Oh, we're gonna turn the mic on. Thank you. There you go.
I'll take the opportunity since you gave me the floor. I just recently started at Keswick Multi-Care Center, but I did want to just note that we just recently went forth with an aggressive expansion strategy for community health and regional partnerships with respect to care transitions and care coordination, because we have a vast array of services, subacute, long-term, outpatient, rehab, and the like. And so we're looking forward to being partners with the HSCRC in the future. And we hope to be a solution to some of these DBR issues.
Great.
Thank you. Thank you.
One other question. So on the next meeting date, really we've said until session is over, it's got to be either Monday or Friday, right? So is there a preference between those two? I'm looking at March as the 2nd and the 6th. Just thinking about it now, I know you don't necessarily all have calendars, but Donna, do you have a regular conference call every Friday?
We do have a regular conference call every Friday now that you mention it.
Okay.
Yes. And it's short now, but it will be an hour.
Okay.
Legislative. And by March, Monday or Friday won't matter because they both will be totally in place. So
okay.
Just do what you have to do.
Okay.
Starting in March, I will be booked on Monday.
So let's settle on Fridays, and then Donna, maybe you can listen in for the And fortunately, the legislature doesn't go on all year. So, okay. Anything else?
Anyone on the phone? All
Great.
right.
Well, thank you all very much. We wish Diane the best of luck with her hip.
I'll be running around here the next time you see me. Thank you. Bye.